Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out the free Top 200 Study Guide, 31-page PDF on some of the most important things that you're going to be tested on, as well as some of the most important things that show up in clinical practice on the top 200 drugs. So, absolutely free to do. Simply an email will get you access. We get you updates when we've got new podcasts and other content available as well. All right, let's get into number 161 through 165. So we've got Liraglutide. I've also heard it pronounced Liraglutide. Probably Liraglutide is the most common pronunciation I've heard. Brand name is Victoza. There's also another product, Saxenda, which is a little bit higher dose. And the indication for this medication is diabetes, and then for Saxenda, that is for weight management or weight loss. Mechanistically, this is a GLP-1 agonist as its classification. It is a glucagon-like peptide 1 agonist that enhances glucose-dependent insulin secretion, slows down that gastric emptying, and ultimately helps reduce postprandial blood sugars. Okay, so those are those blood sugars after we eat. So that's really its major target when we're using it for diabetes. And obviously with weight management, the promotion of that fullness feeling, the slowing of the gastric emptying, that's what can really help patients eat less and lose weight. Adverse effect profile. The way I kind of think about it is if you think about, slowing down the gut, more food sitting in there for a longer period of time, that can cause some issues with nausea. In particular, even, some cases a little bit more severe where we have some vomiting type situations as well. Diarrhea can happen as well. Some rare things that may happen. There is concern in patients with certain types of thyroid cancer, so that's a good thing to kind of inquire about if you're prescribing it or dispensing it or potentially using the medication. So pay attention to that. The FDA is currently, this was in 2024, and I think that investigation is still going on here into 2025 as I'm making this podcast. So FDA is investigating some risks associated with depression and suicidal thoughts. So it'll be interesting to see how that turns out. And that's for the GLP-1 class in general, not just Liraglutide. A1C reduction. So in the management of diabetes, this typically results in a better A1C reduction than, say, DPP-4 inhibitors, for example, or pioglitazone, some of the other oral medications, usually in that range of 0.5 to 1.5 on average. So again, can be patient dependent. You might see bigger drops than that. You might see patients that don't respond as well too. Also with Liraglutide, we've got that cardiovascular protection benefit as well. So in the diabetes guidelines, you see that if patients are needing or could benefit from cardiovascular protection because they're at higher risk, Liraglutide is one of those medications that could be beneficial for that. From a drug interaction standpoint, it's recommended to avoid combining with DPP-4 inhibitors. So Liraglutide and the GLP-1s can be used with most oral medications. However, DPP-4 inhibitors work kind of along that similar pathway as GLP-1 agonists. They help to preserve incretin, which is an important hormone that causes, that can help cause that fullness and that type of thing. So with that, it's got kind of that overlapping mechanism, and it's not recommended to use those in combination. Example, DPP-4 inhibitor is medication like sitagliptin or Januvia is the brand name there. A couple other things, think about low blood sugar risk. So patients on sulfonylureas, on insulin, when we add a drug like Liraglutide, that's going to increase that risk. And then corticosteroids can oppose the beneficial effects of lowering blood sugars. Corticosteroids are definitely associated with causing hyperglycemia. Next medication, number 162, is folic acid. This is considered, a supplement, if you will. Primary uses, malnutrition, patients who are alcoholics or alcohol withdrawal, those type of situations you may see this medication used for. Prevention of birth defects in pregnancy or people who are planning to become pregnant. Usual dosing in that patient population is in that 0.4 milligrams to 1 milligram per day. And then supplement with medications. The most common one you're going to see in practice, or at least the most common one I see in practice, is methotrexate. So methotrexate requires folic acid, or it's recommended to use folic acid with this medication to help reduce some of the potential adverse effects of methotrexate. So again, pregnancy, methotrexate use, obviously deficiency, those are the most common indications there. Now, folate deficiency specifically, I wanted to mention that one of the more common occurrences with folate deficiency is anemia. It's typically called a megaloblastic anemia. The size of the red blood cells actually gets a little bit bigger in this type of anemia. So, paying attention to monitoring, hemoglobin and hematocrit, making sure those aren't dropping. If they do drop, that's one of the things that we rule out is folate deficiency, in addition to B12 deficiency for megaloblastic anemia, and then iron deficiency as well. Mechanistically, folic acid is necessary for the formation of a number of coenzymes and, involved in numerous metabolic systems and pathways. Particularly, it's important for purine and pyrimidine synthesis, also required for nucleoprotein synthesis, and maintenance of erythropoiesis. So that's where that red blood cell formation comes into play, and that risk for anemia if we are deficient in folic acid. Typically, as far as the medication supplementation goes, it's very well tolerated. I can't recall a situation where I've ever come into any adverse effects. I suppose there's potential for some GI upset or something, but again, typically very, very well tolerated. Normal lab levels are in that 2 to 20 nanograms per mil range. So that's an important thing to note there. And then wrapping up, drug interactions, or at least medications I think about that can cause folic acid deficiency. So methotrexate I alluded to already, but there's plenty of other meds that can cause folic acid deficiency as well, and that it should be assessed periodically if you are taking some of these medications. So probably the biggest ones, it's another DMARD medication that can be used for autoimmune diseases, Crohn's, ulcerative colitis, RA potentially, and that's sulfasalazine. So that medication can potentially cause folic acid depletion or lower levels. And then sulfa antibiotics, Bactrim, sulfamethoxazole, and trimethoprim, that combination, that can also cause some folic acid deficiency. Now, typically in a 7-day course, 3-day course, 5-day course, we're treating a UTI or a skin infection or something like that. I'm not going to worry too hard about folic acid deficiency. Probably not going to be an issue for just a short course. Now, if you've got somebody on chronic prophylaxis for something, UTIs or HIV, we may use it for certain prophylaxis for certain bacterial infections. That's the situation with chronic use where I'm probably more worried, about that folic acid deficiency risk. One last one I'll mention, phenobarbital, that can be actually altered. Folic acid actually can reduce the concentrations of phenobarbital. Again, phenobarbital not used much anymore. It's an older anti-seizure medication, but just one last interaction I wanted to mention there. Clotrimazole, brand name is Lotrimin. This is classified as an azole antifungal. Typically, we're not going to use this medication systemically. It is primarily used just locally. So, biggest infections, fungal infections to think about where this medication is used. Vaginal yeast infections, fungal infections that way. Athlete's foot, jock itch, ringworm. Also, orally, we can give what's called a troche. Troche is a small, basically medicated lozenge type medication that dissolves in the mouth and delivers the medication to the body. And obviously, in this case, in thrush of the mouth and throat, we're looking to get that medication to kind of coat that infection in that localized area in the mouth. So that's that dosage form that you may see used in the management of thrush. You've got vaginal creams, topical creams, lotions, ointments, solutions, as you could expect, with a medication that's used to treat many topical fungal infections. We'll say with thrush, pay attention to corticosteroid inhaler use. So if you've got a patient with asthma or COPD that may be prescribed an inhaled corticosteroid like fluticasone, for example, corticosteroids can increase the risk for thrush, that kind of oral fungal infection. So rinsing the mouth properly can help potentially reduce that risk for developing thrush. So in my practice, the prescribing cascade, where you see a patient on an inhaled corticosteroid and you're seeing potentially repetitive use of clotrimazole troche, that can be indicative of the adverse effect of the inhaled corticosteroid. So again, paying attention to that, and remember that new prescriptions mean something. That means that there's a new problem, and we want to make sure that that problem is not caused by other or worsened by other medications. So important to note there. Mechanistically, it binds phospholipids in the fungal cell membrane. That ultimately changes the permeability of the fungal cell wall, and those internal contents of the fungi can leak out and ultimately contribute to the death of the fungus. Topical agents typically going to be pretty well tolerated. We're not going to get much for systemic absorption. So again, from a systemic adverse effect standpoint, typically not going to be too much of an issue as far as adverse effects for most patients. Monitoring, particularly with some of the skin type infections, athlete's foot, great example there. Fungal infections may take a little bit longer to treat, again, particularly with those skin fungal infections. So it's important to educate your patient about that it may take a little while to get full relief and total clearance of the infection. So that's an important point to note there. Typically, yeast infections, we don't need as long a course to treat those. Those tend to go away a little bit quicker. But some of the skin fungal infections may take a little bit longer. So it's important to know that, which infection we're treating, and then obviously educate your patient appropriately. And then drug interactions, not going to spend much time on that. With using topical agents, not going to cause too many drug interactions that way. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, geriatrics, BCMTMS, or the NAPLEX, go check out meded101.com/store. We've got a growing list of resources there. We've helped thousands of pharmacists and pharmacy students prepare and pass their exams. So go check out that content. Support the sponsor, meded101.com/store, and help support this podcast as well. If you're a pharmacy technician, nursing student, other healthcare professional, we've got lots of books on Amazon, unique content, guide to drug-food interactions, guide to drug interactions in primary care, perils of polypharmacy for those in geriatrics, lots of unique books that can help you become a better clinician, a better healthcare professional in whatever field you're working. So again, all those links, go check out meded101.com/store. All right, 164 is Empagliflozin. Brand name is Jardiance. Mechanistically, this is in classification. It is an SGLT2 inhibitor. By inhibiting SGLT2, that's sodium glucose cotransporter 2, this ultimately results in an increase in glucose excretion through the urine. So again, getting sugar out of the blood, and that blood glucose will drop. So that's the beneficial effect there. And that glucose goes out through the urine. That's how it's eliminated from the body. So that can present some challenges and some unique side effects. So first and foremost, with that glucose going out through the urine, that may provide a more beneficial environment for bacteria and different infections to grow if we're giving them essentially sugar to help feed them. Okay, so maybe a little bit higher risk for genitourinary type infections. Also a slight risk with ketoacidosis, and this may present as euglycemic ketoacidosis, where the blood sugar doesn't jump too high. I've posted about this at meded101.com before, so if you search euglycemic ketoacidosis, SGLT2 inhibitors, if you Google search that and Meded 101, you should see that article on that, which goes into a little bit more depth. Hypoglycemia risk can happen. Obviously, that's increased when we're using sulfonylureas and insulin with the medication. Has been some negative press on bone fracture risk, so that's something to pay attention to as well. And then with that glucose also goes potentially some volume, some fluid. So there can be a modest drop in blood pressure, can be some volume depletion risk and increased risk for dehydration. Again, probably exacerbated a little bit more so by other medications such as diuretics. So that's an important thing to note there as well. All right, let's talk a little bit about some of the other effects. So we've got some protective effects. Empagliflozin can be beneficial there in reducing the risk of cardiovascular events. Also, these medications, this class of medication, is a backbone in heart failure treatment now. So that's even in patients without diabetes. Again, and if you think about it, we've got some mild diuretic type effect to this medication, and that in addition to some of the other evidence and benefits that have been shown leads this medication to be a beneficial medication in heart failure as well. Also benefit in reducing progression of renal disease or CKD. So again, really, really important, kind of compelling indications. It's not just a diabetes medication anymore as it was when it initially came out. So those are important things to note and pay attention to, for prescribing and dispensing this medication. As far as blood sugar lowering effect, A1C lowering, I would say it's probably not as potent as like GLP-1 agonists. It's typically less than 1 point when used on its own, but obviously if we use it in combination with other agents, we may drop those blood sugars in that A1C a little bit further than that. Wrapping up with drug interactions on this medication. So I think about the diuretic effect. So you add it on to loop diuretics, we could, potentially increase that risk for dehydration, for example. I also think of immunosuppressive agents. Sending that glucose out through the urine, we may increase the risk of infection. And if you got a patient that's already on an immunosuppressive, that risk maybe could go up a little bit. That low blood pressure effect. So if you've got a patient that's already too low, maybe they've got some orthostasis, fall risk, that type of thing, that modest reduction may drop them further with a drug like empagliflozin. And then hypoglycemia, obviously we can have some additive effects there. If you got a patient on sulfonylureas, insulins, we can have some additive effects there. So those are kind of the big things I think about when I think about drug interactions with this medication. All right, last we got 165, Semaglutide. Brand name is Ozempic. Also Wegovy, also Rybelsus. So lots of different brand names there. Ribelsis, I'm not seeing a ton used in practice. It is oral. Can take this medication orally. There is some strict administration, 30 minutes before food, beverage, and other medications with oral semaglutide. So again, that is the Ribelsis product. It's also dosed twice daily as well, I believe. So again, I'm not seeing it used a ton at this point in clinical practice, but at this point it is still out there and available. Ozempic, that is the brand name agent that's kind of focused on diabetes or been studied for diabetes. And then Wegovy is the weight loss product, which you may have heard about a ton in the news and that type of thing. So the dosing, I will talk a little bit about that. So both Ozempic and Wegovy are injectable agents. The higher dose is typically for Wegovy and weight management. So that's up to 2.4 milligrams. And then the Ozempic product for reduction of blood sugar and managing diabetes, that is a 2 milligram max dose. So again, kind of the dosing differences are what the big difference is there. Same medication, everything, all adverse effects, all that sort of stuff. Dosing for the weight management product is a little bit higher. So GLP-1 agonist, mechanistically, how does that work? It enhances glucose-dependent insulin secretion, slows gastric emptying, and again, targeting kind of that postprandial blood sugar, trying to bring that down in the treatment of diabetes. Major adverse effect, GI, nausea, vomiting, potentially some diarrhea. I alluded to that in the Liraglutide as well. Again, promotes that fullness, and that weight loss certainly can be a beneficial effect if we're treating diabetes even in our overweight type 2 diabetic patient population. That FDA investigation is ongoing. I alluded to that as well previously. Rare concern with thyroid cancer. Pay attention to that. Ask patients about any family history of thyroid cancer or thyroid issues, and then investigate that a little bit further just to make sure that this medication is safe for them to use. So this is a once-weekly injection. That differs from Liraglutide, which I hope I mentioned that. Liraglutide is a once-daily injection. Semaglutide obviously is more advantageous, where patients only have to do that injection once a week, and that's both for semaglutide and the Ozempic product for diabetes and the Wegovy product as well there. The cardiovascular protection is proven with semaglutide. That A1C lowering effect, again, it's going to be about a point, give or take a half a point. So it's a decent amount that it's going to drop those blood sugars. And then drug interactions wise, wrapping this up, again, a lot of similarities with Liraglutide. Avoid combining with DPP-4 inhibitors, again, that overlapping mechanism. Low blood sugars with insulin, sulfonylureas, that risk increases. And then corticosteroids kind of directly oppose the effects, can raise blood sugars when we're trying to actually reduce them with the medication semaglutide. All right, well, that's going to wrap up the podcast for today. If you found this helpful, please do me a huge favor. Leave a rating, review on iTunes, wherever you're listening. Support meded101.com. I greatly appreciate that. Any purchases there go directly to help support this podcast. And if you got any questions, comments, concerns, feel free to reach out to me, mededucation101@gmail.com, or you can track me down on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. With that, please continue to share the podcast with friends, colleagues, pharmacy students, med students, anyone who could benefit from some pharmacology education. I greatly appreciate that. And I thank you so much for listening, and I hope you have a great rest of your day.